We are now recording, and we are also streaming live on Facebook. So we're going to begin. Hi, my name is Dr. Carolyn Rowley, founder and executive director at Cayenne Wellness Center. Good morning and afternoon, everyone, and welcome to Cayenne Wellness Center's Sleep and Sickle Cell Disease Part 1, Good Sleep, one of the keys to managing pediatric sickle cell disease. We're going to start with a pre-test, and then we're going to get into our seminar. So we're asking if you all can do the pre-test. We'll have a pre-test and a post-test, and we're going to start the pre-test at this moment. And it does appear on your screen if you all can participate. And so Golda, I'll let you take over regarding the pre-test.
Yes, y'all, it should be on your screen. So please just go through and to the very end, just 4 questions. Shouldn't take long. Thank you so much.
Okay, so we have 4 questions. We'll give you all another 50 seconds to answer the 4 questions. That'll be about 2 minutes. Okay, so about another 30 seconds. If you're just joining us, we're doing the pre-test, and we'll do the post-test towards the end. And we have another 20 seconds. Okay, we're going to end the poll now. Thank you for participating. So again, if you're just joining us, and if you want to be able to share the results, let's see. Okay, there we go. If you're just joining us, again, my name is Dr. Carolyn Rowley, founder and executive director here at Cayenne Wellness Center. Our mission is to increase the quality of life for individuals diagnosed with sickle cell disease in California by ensuring expert, unbiased, and comprehensive care. This mission is part of a broader vision of a medical system which effectively addresses the unique needs of individuals with sickle cell disease and patients who are empowered and equipped to advocate for themselves. I would like to go over just a few of some of the other calendar events that's coming up. We've had quite a busy year thus far. We have so many activities coming up for the remainder of April, then June, May, and June. So next Friday will be the introduction of our Author's Corner. These are books written by sickle cell warriors, and we're highlighting them. We've actually done this in the past during our 3-day educational seminar. And so, but with the many books that are out there, we figured that we would do like a Friday fireside chat. And so next Friday, we're featuring books for children. So come join Jenna Kalea, Tanya Gentry, and that session is going to be moderated by none other than Dr. Kim Smith-Whitley. Again, it's an hour and a half Friday, starting at 4 o'clock Pacific time. So it should be really great to be able to see my friend Jen. That's one of the books. Pee-wee Goes to School is another book regarding sickle cell disease. And then we're going to be talking about how to help children live their best life. So it's like an open forum. Then in May, We're going to have the last of our brain and sickle cell disease that's been very popular. Part three, bringing families and schools together. Again, moderated by Dr. Lance, and that one's going to be on May 22nd. June 19th, of course, please join us for our Marathon Sickle Cell Disease World Sickle Cell Day. We did this last year. Some of you stayed up with me, 24 hours. We're going to have a great agenda as well, but we will be starting from 12 midnight to 12 midnight the next day. And we're doing that in partnership with the Sickle Cell Community Consortium. Then in June 26th, we're having our mini seminar on mental health and sickle cell disease part 2. And so that one is called Mental Health with a Kick. Last time we had mental health with a twist, and we did painting. And so this one is with a kick. That one is moderated by Dr. Jonah Saint, and the speaker is Lori Crosby. The activity afterwards is going to be dance therapy. And so never participated, but dance therapy they have for anxiety, for depression, for trauma. So that's going to be something to come join us. All righty, I want to be able to thank our staff, the beautiful Golda that you're able to see now, our program director, and who's going to be co-hosting and helping with technical issues if we have any today. But now I'd like to introduce our speaker for the sleep and sickle cell disease, Dr. Cecilia Valerie. Dr. Valerie is a developmental health psychologist with a program of research aimed at improving the health and well-being of youth and young adults at risk for poor health outcomes, and a special focus on youth with sickle cell disease. She is currently an associate professor in the Department of Psychology at Virginia Commonwealth University and an adjunct associate professor in the Department of Internal Medicine at North Carolina at Chapel Hill, and her BA in Psychology and Math at East Carolina University. The majority of her work has centered on understanding the pain and sleep experiences of pediatric sickle cell disease patients, reducing pediatric health disparities, and developing effective pain and sleep interventions. Her research has been funded by the National Heart, Lung, and Blood Institute and ASH, the American Society of Hematology. She has been published in the Journal of Pediatric Psychology, the Journal of Developmental and Behavioral Pediatrics, Pediatric Blood and Cancer, and Sleep Medicine. I'm really thrilled to have Dr. Valerie do this talk. We've been talking about it. This is the first one. The next one will be on adults, so you definitely want to come back. And then the last one's going to be on NAP ministry. Yep, you heard me say NAP ministry, a whole ministry on napping. But without further ado, Dr. Valerie, take it away.
Okay, well, I hope everyone can hear me pretty well. I'm really happy to be here talking about sleep, and particularly sleep and its relationship to sickle cell is really one of my passions. So happy to join you guys. So let me start by sharing my screen. Okay, hopefully you can see, I can see, you might be, I think I've heard sometimes when I'm presenting in Zoom, where the faces are turns into kind of a little blank spot. So I'm going to actually minimize those. So you may or may not be able to see me. It's always hard to see as a speaker. But today I'm going to be going over sleep and sickle cell, a pediatric perspective. In reality, because kids grow up, I'm also going to be providing a lot of information on sleep and things to think about in sleep in adults, because a lot of the way I think about focusing on sleep during childhood is because eventually these kids are going to have to grow up. We want them to have long-term success. And I think part of long-term success is being able to sometimes focus in on these behavioral aspects. And I think sleep is one of the keys to that. Okay, there we go. So my objectives for the talk today are to first discuss why sleep is so important for both understanding and addressing in youth with sickle cell disease and their families. And then I want to review a little bit of the literature on common sleep problems. So what type of sleep problems are youth and adults with sickle cell disease likely to face? What are ones that we need to keep our eye out for? And how are they related to some more negative outcomes associated with sickle cell disease? And then I'm going to discuss very specific strategies for how do we figure out if, let's say, your kid or if you, per se, are experiencing sleep problems, and then what are we able to do about them? I think every once in a while I might also stop because I think a Saturday afternoon, for me, it's the afternoon. I think for you, it's a little bit earlier. An hour is a very long time. And so I want to be able to make sure that I'm addressing things as I move forward. So let me get through maybe the first bit of information, and then and then I'll probably circle back for some early questions before I finish up. So one of the first things I really like to emphasize is sleep is so important for sickle cell disease because it's so interrelated to a lot of places where we know that kids with sickle cell disease are likely to have problems. And all of these kind of connections in this model that I'm showing you guys have all been supported with research with individuals with sickle cell disease, is that we know that poor sleep tends to be very strongly related to pain. That's one of the big relationships that we keep our eye on, but it's also related to higher risk of mood disorders like anxiety and depression, other disease symptoms, including cardiac issues, acute chest syndrome, pulmonary hypertension, and then also linked to kind of a side connection that I'm going to talk about connected to sleep, which is fatigue, the daily exhaustion that individuals with sickle cell disease face, including children. And fatigue is a big issue among kids with sickle cell disease that we're just now becoming more and more aware of. And then both of these factors being related to cognitive issues. And there it could be issues with inattention, memory, impulsivity, but all of that then translates into academic problems. So problems that kids could be facing in school because of the exhaustion and cognitive fog that happens because of poor sleep, but also that happens because of resulting fatigue. Now, kind of focusing in on the relationship that I think the majority of people have spent their time looking at, a large amount of people early on in looking at sleep in kids with sickle cell disease and sleep in adults with sickle cell disease just assume that poor sleep was just because of pain. Individuals are sleeping badly because they're experiencing pain in the night. It's disrupting their sleep patterns. Once we get pain under control, everything will be wonderful and beautiful, and sleep will return to being restful. However, that is not the case, in that what we tend to see instead is a back and forth relationship. Is not just that pain impacts sleep, but that sleep, when it's disrupted, even not in the presence of pain, can actually lead to or promote or contribute to pain. And so in that sense, we really kind of delved into what's likely happening in relation to sleep, is that sleep is a core part of how you're of the repair of your body. It helps to regulate your immune system in such a way that when sleep is disrupted, you might have increased inflammation. And increased inflammation plays into the pathophysiology, plays into the overall physical aspects of pain and of overall sickle cell disease. Another thing that sleep does is it lowers your pain threshold. So for anyone who's ever just had a very bad night of sleep and then woken up and everything just aches, it's not because you have been fighting it out in the middle of the night. It's more likely that what has happened is your pain threshold has fallen so that even minor bumps that you've had during the night, everything is reading as pain. And when you have a good night of sleep, those sensations will not be there. So it can actually make existing pain worse. And so those are the different ways. And then as we started moving to actually looking at measuring pain and sleep over time, so more than just one time, but like over the course of days on a daily basis, and even starting to move towards looking at sleep and pain patterns over years, we actually realized that it's much more of a flipped relationship. Sleep tends to be a better predictor of pain than pain is of sleep. And that makes sleep a great target, actually, if you want to reduce future pain experiences. If you possibly want to get ahead of the idea of people going from continuous small level pain episodes to more chronic pain that we tend to see in adulthood. And as we delve into it, we're starting to see this relationship not just for sickle cell, but this is actually something that's being echoed for other populations that tend to experience what we call recurrent pain. So pain that tends to come back over time, is that sleep is really playing an important piece of this. And that with a lot of kind of early intervention work, we're noticing that if we can actually improve sleep, at least in these populations, we tend to can actually reduce pain. And that's wonderful. And diving into why this might be, and I know this slide is kind of busy, but I'm going to actually break it down a little bit, is there's a number of different ways that sleep can possibly lead to pain. The biggest ones are really around these three areas: inflammation, which I think I've mentioned before, your emotions. What we found is that anxiety, depression, those kind of more negative emotions, but also the reductions of positive emotions, things like joy and calmness, all of those can actually have a very specific impact on your body that can actually increase the pain experience. And then even how your body reads sensation, how it reads somebody touching your arm, how it reads you falling down, how it reads different kind of stimuli from the environment. So influences, all of that's being influenced by your sleep. And all of that coming together leads to increased pain, which then cycles back and can lead to worse sleep. So that also gives us a number of, I guess you could say, both behavioral as well as physiological targets to go after to try to break this relationship. And really speaks to the value of just, if we can impact sleep, we can impact just this cascade of things downstream. Okay, so all of this should kind of hopefully be giving you the very clear message that sleep is sitting at the intersection of a lot of different sickle cell symptoms. And if we can get our head around how to effectively change sleep within for kids with sickle cell disease, this is a skill that they might then have lifelong that could then impact all the rest of these symptoms and how they progress over time. So let's take a look at some common sleep problems experienced by people with sickle cell disease. And these are going to be the 4 that I take a look at. I'm kind of adding in fatigue as kind of our daily indicator of sleepiness. And I think based upon at least the initial survey, I think that many people kind of know many of these or have heard of them. But I'm going to give an overview of what we tend to focus on when we think about sleep, because there's a lot of different aspects of sleep. One of those aspects that we tend to focus on is how long do you actually need to sleep? So sleep duration. And that, of course, changes over the lifespan. These are the current recommendations for how much sleep you're supposed to be getting, based upon information from the National Science Foundation. And as we notice, going from infancy all the way to the end of the teenage years, there are a lot of changes. But still, even at the teenage years, 14 to 17 and onward, we think that kids need at least 8 to 10 hours of sleep. So 8 on the minimum. School age kids, so we're talking about our middle schoolers, our elementary school kids, at minimum, lowest number should be at least 9. And then earlier than that, even more sleep. Part of what's going on is we think that this sleep, particularly early in life for newborns, for infants, for toddlers, is actually helping their physiological growth. It's helping their brain to process information and all the new information that they're taking in during the first year or 2 of life. It's helping with physiological growth in relation to height and weight. And it's also just, it's putting all the systems in line for the rest of your life. It's even impacting how you're going to process stress for the rest of your life. So these are good recommendations, but this isn't where sleep stops, because sometimes you can get the amount of sleep that you need and it doesn't feel good and it's not great. And so these are actually all the different aspects of sleep that I tend to focus on. One is sleep quality. When you wake up in the morning, does it feel good? Can you say that was a really refreshing night of sleep? I feel rested and ready to take on the rest of the day. Or you wake up, it's been 8 hours, it's been 9 hours, and you still feel tired. You feel grumpy. You feel not satisfied. That has actually been related to a number of different outcomes when you're not getting good sleep quality, particularly when you look at issues with processing information, issues with depression, issues with anxiety. It can definitely be played into with sleep quality. And we're now starting to notice that this, just your simple report of whether or not your sleep was good or bad, tends to partially be related to something we call sleep efficiency. And this is the amount of time that you spend in bed versus the actual amount of time that you spend sleeping. So let's say that you spend 10 hours in bed, but you only spend about 5 of those hours sleeping. And you spend the rest of it tossing, turning, playing on your phone, watching TV, then you have got low sleep efficiency. If you spend 8 hours in bed and 8 hours sleeping, that's 100%. For us, we generally want to see at least 80% efficiency, where it doesn't take you too long to go to sleep. You're able to go to sleep within 30 minutes of coming to bed. If not, you're really not using that bedtime very well. And that could be reflected in what happens the next morning when you don't feel refreshed. So that's something to keep your eye on. The other things are more classic clinical sleep disorders like insomnia and sleep disordered breathing. And insomnia is a much more of what we call a behavioral sleep disorder. It's an issue falling asleep, staying asleep, or both, versus sleep disordered breathing. That's actually a group of disorders, the biggest one being obstructive sleep apnea, which I think has gotten a lot of airplay in the last 20 years or so, where you're having problems actually breathing during the night. For obstructive sleep apnea, people actually stop breathing throughout multiple times throughout the hour, generally 5 or more times per hour. We say is obstructive sleep apnea. And that can be incredibly dangerous. So I did want to focus in, however, on the difference between pediatric sleep apnea versus adult sleep apnea. So if you're able to see the screen right now, what you should be noticing, particularly on the right, is oftentimes with kids, when we're talking about sleep apnea, it's due to what we call enlarged adenoid and tonsils. So that's why the standard treatment, if you think about sleep apnea for children, is what we call adenotonsillectomy. It's a surgery to remove the adenoid tissue and to remove the tonsils as a way to make way for air so that they can more easily breathe during the night. In contrast to that, what's going on for older adolescents and adults is not anything to do with adenoid tissue or large tonsils. It's actually to do with, I don't know if you can see my cursor, but with the palate and a portion of the palate that tends to kind of drop down and block airway. Now, we're not going to reduce the size of the overall palate. It's needed for other functions. So instead, what we do for adults tends to be continuous pressure airway treatments. So there you'll notice the CPAP machines where they're technically forcing air down your throat as a way of lifting that palate up to get the air that you need in order to keep breathing in the night. So there we notice the differences between sleep apnea for kids is going to lead to surgery versus for adults is more likely to lead to a completely more continuous intervention that is long-term. And we'll get into that a little bit later when we talk about standard treatments. Okay, so what is the, hold on, I'm going to take a little water. Okay, so if we're dealing with sleep disordered breathing, sleep apnea, what do we know? How often does it occur in individuals with sickle cell disease? Based upon our best estimates, anywhere from a third, so 36 to 44% of individuals with sickle cell disease have or develop sleep disordered breathing. We do not have the exact estimate for how common this is among kids. I wish we did. But based upon some child-based studies that are more intervention studies, it seems to be just as common among kids and adults. It's related to increased pain, risk of stroke, daytime sleepiness. And when we look at other outcomes, one of the big ones being snoring, academic problems, fatigue, and frequent and intense pain. There's actually, I believe, a recommendation out there for kids who experience very frequent, intense pain that they be checked for sleep disordered breathing. Because what more than likely might be happening is during the night when their body is getting less oxygen, it's promoting more sickling, which is promoting more vaso-occlusive episodes, so more pain-based episodes. And so that's a very common sleep problem, about a third of individuals with sickle cell disease. However, we've got another concern. That other concern is periodic limb movement of sleep. Now, this is one that I think there's a lot less information out there in the sickle cell community, and there's been a lot less research focused on it. And it's this rhythmic, repetitive limb movements during sleep. And it's generally just a portion of your leg or foot moving around for 2 to 4 seconds, a few times a minute. But this can actually be incredibly disruptive. In kids, we found it to be related to heart disease. And in adults, we found it to be related to a number of clinical indicators of disease severity. And we think it's pretty prevalent, but it's often not addressed, or we're not finding it to be largely addressed in youth and adults with sickle cell disease. So in 2 studies of kids, we found it to occur in around 20 to 42% of kids. And for adults, 70% who are experiencing what they for adulthood are considering to be kind of moderate periodic limb movements, at least 5 per hour, and a third with incredibly severe, so over 15 per hour. So we see that the risk of periodic limb movement tends to be escalating over time for individuals with sickle cell disease. And then we've got our behavioral sleep problems. We've got our insomnia. And as I mentioned before, it's trouble falling asleep, staying asleep, or both. We've related that, at least in other populations, to a number of kind of particularly academic issues, fatigue, negative mood. For kids with sickle cell disease, also incredibly common. We're finding 20 to 40% who report clinically significant behavioral problems. What I found very interesting are the studies that actually pull apart whether or not these behavioral sleep problems are because of sleep apnea. And what we're finding is that no, what we have instead are 2 different sleep issues going on, sometimes at the same time, but sometimes completely separately. So behavioral sleep problems are not often just caused by sleep apnea. They can stand on their own. They are powerful enough to do that, and they appear as often on their own. An interesting survey of youth with sickle cell disease, particularly I think these are pre-adolescent to adolescent kids, found that about a third reported disturbed sleep at least once a week. About 30% were taking some type of sleep medication once a week. And in talking clinically to a number of kids, sometimes, unless you ask very specifically, I will say us healthcare providers don't always know that individuals are taking sleep medications on top of things, whether that might be Ambien or whether that might be melatonin or some other sleep aid. I think it's very important because these different chemicals might interact with some of the other things that you've been prescribed or that your kids have been prescribed. And then we've got another 20% that also report that their sleep disrupted their day-to-day lives. So these behavioral symptoms are not just present, they're also incredibly disruptive. I know our group did a study comparing adolescents with sickle cell disease to other African-American adolescents to find that they tend to experience more sleep problems than adolescents who are also Black. And we noticed that when you start looking into the adult literature, it just seems to continue to get worse. 40 to 71% of adults with sickle cell disease reporting significant behavioral problems. At this point, being completely diagnosed with insomnia and demonstrating insomnia symptoms, difficulty falling asleep in less than 30 minutes, and just being awake for long periods after sleep onset. And we're going to delve into what some of those reasons might be a little bit later. But all of that still comes together, those behavioral issues of that's what's happening at night, but what about what's happening during the day? And so that's leading me down the pathway to talk about fatigue. Now, we really didn't have our eye on fatigue until I'd say about 10 or so years ago. But fatigue has been an issue, I guess you could say, more seen in primary care and other populations. But fatigue here we're going to define as an overwhelming, debilitating, sustained sense of just exhaustion that tends to impact your life. We know in other populations it's related to everything from anxiety and depression to social withdrawal, just not having the energy to interact with others. It can show up as mental or cognitive exhaustion and just problems doing day-to-day activities. What was this interesting FDA project called the Voice of the Patient back in 2014, where they were wanting to make sure that drugs were being designed to really impact all the symptoms faced by individuals with sickle cell disease. So they went to individuals with sickle cell disease, they went to different stakeholder groups, they talked with their families, and without even asking about it, spontaneously, fatigue rose and appeared as one of the top 3 health effects that sickle cell disease had that was impacting the lives of people living with sickle cell disease. And they were using words to describe it as great bouts of fatigue, tired and feeling like a dead weight, but your mind racing, your body won't cooperate, this heavy overarching feeling. And moving on with this study, what they found was that it tended to really have this huge impact on their daily lives, needing sleep all the time, feeling tired all the time. Interestingly enough, it seemed very unrelated, according to patients, with pain and with their hospitalizations, but somewhat related to their insomnia symptoms and their sleep problems, sometimes, but not always. One individual in the study described it as being caught in a vicious cycle of insomnia, which further aggravates fatigue. And someone else said, it doesn't matter how much I get, or how many vitamins I take, exhaustion is just my reality. Now, after this study, we started really taking a better look at fatigue, and also not just in adults where we find it to be really a lot, really common, but also in children. Some early studies have already related fatigue in kids with sickle cell disease to mood disorders, like we'd expect, symptoms of anxiety, depression, overall stress, poor quality of life. But it's also been related to working memory and executive functioning issues, all the issues that are going to lead to academic problems down the pipeline. And thinking about how common it is, I think we've really been surprised by how common it is even among adolescents and young adults. So they did a survey where they found about 69% reported experiencing fatigue in the past week. In studies where youth with sickle cell have been compared to control groups or youth with cancer, they've been actually found to have more symptoms of fatigue than those two groups. And for some kids with sickle cell, this interesting interview study of 11 adolescents with sickle cell, they found that fatigue occurs more often and was reported to be more problematic than pain for these adolescents. Now, our group actually did an interview study of 98 to 17-year-olds, a structured interview. And what we found was that about 75% of our sample reported experiencing fatigue within the past month. The majority reported that it was, we call episodic. So it came and went. And when we actually looked into these fatigue episodes that we call them, they're reporting on an average around 7 episodes per month, lasting on average anywhere from 10 hours. And they were pretty severe on a 10-point scale and tended to also be interfering in daily life. What was particularly interesting to us is that adolescents tended to report longer fatigue episodes than children. So this seems to be something that's escalating over time. And based on Guardian and self-reports, adolescents also reported more what we call cognitive fatigue. So problems focusing because of this extreme tiredness that was impacting them academically. So overall, all of this should be kind of giving off the message, sleep is important, sleep has an impact, and youth and then later on adults are going to be experiencing a lot of issues with sleep, things that we can actually address, I believe, within the population because of the work that's been done with other populations. So I'm going to pause briefly here to see if there are any questions before I kind of go on to evaluating and managing sleep problems.
Yes, there are. So thank you. So I wanted to remind everyone that, first of all, this session is being recorded and it will appear on our website in about a week. Feel free to post your questions in the Q&A as well as the chat. The first question comes from Jemima and says, does sickle cell disease affect ability to fall asleep, even when they have no pain? Does it affect ability to wind down and fall asleep?
Yes, it does. That's that whole insomnia piece, problems going to sleep, staying asleep, and feeling refreshed in the morning. And we have definitely found that sickle cell disease tends to be related to that. Now, how exactly it's related to that is where we are having our biggest problems. And I've got some speculations as to what I believe is going on, why I think that sickle cell places people at risk and how that's going to play into management. So I'll be able to get more into that as we kind of go on.
Okay. And I see that there's a question in the Q&A. Go there. Ah, okay. Thank you. It's a statement called great presentation.
Yeah.
Okay.
Thank you. Any other questions before we continue? All right, thank you.
Okay, well, I will keep moving forward then. Okay, so in relation to thinking about management and evaluation of sleep problems in individuals with sickle cell disease, I always like to come back to what I know, which is that sleep is embedded in these other symptoms. So I can't take into account or measure what's going on with sleep without taking those into account. And I think we can do this both at the family level and also in relation to the work that we can do, that families can do with healthcare providers. There's multiple ways in which you can measure sleep, or in which we kind of professionally measure sleep. And so I want you to kind of know what those are and what the purposes of each of those is. So there are the more what we call objective assessments. This is going to be polysomnography. I like to call them overnight sleep studies. And I'll describe each one of these in detail in a second. The other one is sleep actigraphy. So these don't require any input or significant input from individuals who are being evaluated. In contrast to that, we have what we call self-report or guardian report surveys. So we can either do these big one-time, very general or specific surveys, or we can also do daily diaries. And I will say daily diaries or daily surveys asking about your sleep have been a common practice in sleep research and sleep evaluation and management clinically, probably long before they became popular more broadly. So they are almost considered to be the gold standard along with overnight sleep studies. So these are what people picture for overnight sleep studies. And this is still what's going on for pediatric patients. So an overnight sleep study is when they're going to bring you in, they're going to simultaneously, so at the same time, be measuring multiple things. Brain activity to look at kind of how your brain is functioning during sleep. There's slow wave sleep. There's, as you're supposed to dip through these different cycles of sleep that I'm not going to go into. They're also checking in relation to your overall airflow. Is it being disrupted in the night? Do you possibly have signs of some type of sleep disordered breathing? Are you snoring? So they're also even assessing for that as a good indicator of sleep apnea. And a belt that's generally around the waist. And then they're also measuring, generally like not listed on here, like a pulse oximeter that's measuring the amount of oxygen floating around in your blood. And then they're overall also videotaping you to see, are you moving around a lot? Are your legs moving around a lot? Is that a sign of periodic limb movement issues? So it's a very comprehensive assessment. And this is generally going to be the assessment if you're looking for sleep apnea, but it's also very helpful for picking up on other types of clinical sleep disorders. Now, this is currently where we are at for sleep studies for kids, but this is where we're going. So any of you who have maybe experience of sleep studies as an adult, we're already here for some adult centers that do sleep disorder research, or actually sleep disorders and address them clinically, is that we're moving from like this whole thing that has to happen in a specialized clinic where you have to go and stay overnight to actually be doing home-based overnight sleep studies, where people are being sent equipment and trained in how to use it. We've now got apps on the phone combined with this equipment. So this is an example of one that is currently being used for research purposes. And I think they're trying to get validated for use in pediatric populations to assess for sleep apnea and other aspects of sleep. All it includes is a wrist monitor, a sleep actigraph, which we're going to go into in a second, a pulse oximeter, so it's measuring the amount of oxygen floating in your blood, and then an additional sensor that's actually put on your chest that can get at your breathing. So actually through the movement of your chest, it's getting at your breathing. I'm not sure if this particular sensor also has some audio, so it can actually assess if you're snoring or not. But this is where we're at, and this is where we're going. And I think that's going to make it very exciting once we can move that into pediatrics, because it's going to lead to much faster sleep studies, ones where they're happening a lot more within a home-based environment, so that we can really get a comprehensive view of sleep. Another thing that's starting to be used more clinically, but that's been used a lot more in research for decades, are sleep actigraphy. And sleep actigraphy are just mini computers that are fashioned as wristwatches, and they're measuring sleep-wake patterns by looking at how much you move around. So they're activity-based sleep assessments. And many years ago, I want to say back in the early 90s, 2000s, there were particular algorithms that were developed to actually, based upon that movement, assess whether a person was actually sleeping or whether they were awake during the night. Now, we've actually found sleep actigraphy to be pretty consistent with polysomnography, so with overnight sleep studies, in relation to getting at behavioral sleep issues, things like, and behavioral sleep patterns, so sleep duration, sleep fragmentation, how efficient your sleep is. Those are wonderful. And I will say, I think this technology then has been copied into a lot of our own home-based technology that we have. So that's going to be built into our Apple Watches, built into our Fitbits, built into all those different things that are also giving people a sense of where they're sleeping, what their sleep duration is, their sleep qualities. Right now, clinically grade actigraphies are still a lot more accurate, but people are starting to use more and more, because they're getting more and more accurate, the information from those other home-based devices that are coming through the market. Garmin, iPhone, Apple Watch, all of those pieces. Okay, so if we're looking at surveys, there are a number of validated surveys to also get at more insomnia symptoms, and also a little bit in relation to indicators of sleep disordered breathing. The big ones to keep your eye on if you're thinking about, I just want to get a clear sense of if my child might be experiencing a sleep problem, if I need to bring this up or try to do something. The two that I would recommend, or the three or so I would recommend, are, one is the Bears assessment, and the Bears assessment is readily available. I'll go into it in a second. And the other two are, for one thing, asking if your child snores, or if you notice that your child snores. If your child snores, it's an indicator that they might have sleep apnea. It's not 100%, but we actually, in the sleep field, take that as one of the best indicators and predictors of if a child should be assessed, or even if an adult should be assessed for sleep apnea. Because that snoring might actually be more like a snoring that's snorting. So that might actually be somebody trying very hard to breathe because they've stopped breathing, that kind of gasping snore. And then we've also got, for assessing insomnia, sleep diaries are still one of the best methods that are used clinically, that have also kind of seeped their way into the market, both into apps as well as just available on the internet. So let's take a look at the Bears. And I actually even pulled these questions of the Bears, which is publicly available, so out there on the internet. They're all just a series of 5 questions. And each of these questions screens for a specific type of sleep issue. So one would be bedtime problem. So let me focus on the questions for adolescents. So for bedtime problems, the only question is, do you have any problems falling asleep at bedtime? If a child says yes, then that might be a sign that we need to do a deeper assessment. Excessive daytime sleepiness is going to be our E. Awakening during the night is our A. Regularity and duration of sleep is our R, and S is snoring, which is going to be our indicator of sleep disordered breathing. And each of these is one question that can either be asked to the child. Generally, we see asking the children being recommended more for adolescents, even though the snoring one we still ask parents a lot, because sometimes adolescents don't know that they snore. Sometimes individuals don't know that they snore. And then asking more of the parents when kids are younger. So when they're toddlers, it's all parent report. School age kids, you can start asking them and the parents as well. And then we've got our wonderful sleep diaries. So this is actually a sleep diary that I pulled off of Pinterest. I did not create this on my own. And I saw a number of different ones, and this was the one I liked at the time. And what it does is, just looking at a week's worth of sleep. What time did your bedtime routine start with your child? What time did your child go to sleep? What time did they get up? Did they get to sleep? So that's starting to get at that sleep efficiency and that sleep latency. What time did they get up in the morning? How many hours did they actually sleep? What were they doing right before they went to sleep? Were they up during the night? How many times? Did bedtime go as planned? Did they have energy in the morning? What tended to work well, what didn't? Just keeping a record every day of what might be going on can give you a real snapshot as to whether or not your child might be experiencing sleep problems. And I will say, though I haven't explored the market greatly, a lot of this is now being built into sleepy time apps and sleep intervention apps, many of which are free. So I think this can both be done as like a chart that you can print out, a diary. This is all the diary is, or this can be done electronically as well, and brought in to talk with your healthcare provider about. This is another example. This is actually a sleep diary from the American Academy of Sleep Medicine. that was a lot more simple. It's not getting at the things that are going on during the night. It's just literally looking at the schedule of about what time people are waking up in the night, about how much time they're actually getting in bed, and just giving a nice snapshot, something that you can look at, that you can work from, but something that also you can show to a healthcare provider that's going to give a snapshot of your child's sleep. Okay, so after evaluation, after figuring out there might be a problem, there are a number of things that you can either look into yourself or work with your healthcare provider on. One of the first steps for that is if you suspect some type of behavioral or even other type of sleep issue, is one of the first things I say is look for other conditions or treatment aspects that might be impacting it. So is your child waking up because of a lot of pain in the night? Are you often having to comfort them because of their pain? So is addressing their pain going to be the issue? Or could it possibly be pain or other types of medications that they're taking? A lot of medications have side effects where they're impacting sleep. And if we're not paying attention, your child could be taking one that's having a huge impact on them, where it might not be kind of their underlying sickle cell. Or it might be other issues. Are they particularly anxious? Are they particularly depressed? If we address those symptoms, would they actually address the sleep issue? And I know this is kind of hard because the sleep issue might also be contributing to why your child is really feeling frustrated or tired or depressed. That if they got a good night's sleep, that might be the issue. The other piece that we can handle on our own, particularly if we believe it might be insomnia, is starting to be really supportive of proper sleep hygiene. And this is both very simple and very hard, because there's often a lot of stuff going on at home that can impact your sleep and therefore your child's sleep. But these are good questions to ask. Do they have a bedtime routine? Do they actually have a regular sleep schedule? And by regular, I mean that they go to bed at around the same time every night and wake up around the same time every night, including the weekends. Is their schedule actually consistent with life? Or is it just the optimal one that you would hope for that doesn't really happen? Are they drinking caffeine within a few hours of going to bed? So that could be in the sign of coffee, that could be in the sign of sodas. That can also be hidden in products that you're not even thinking of. For example, most people that I know assume that orange or colored drinks that are like grape or orange or red, they don't tend to maintain or have caffeine in them. However, one drink that is different is Sunkist. And since I'm a huge fan of Sunkist, I know that it's one of the few orange drinks that actually has caffeine in it. So making sure that I know exactly what's going into the stuff that I'm eating, making sure caffeine hasn't slipped into my diet and definitely hasn't slipped into my schedule a few hours before I go to bed is very important. And then, is their sleep environment set up for sleep? And if not, how can we make it better? So let's look at what this is all going to entail. One, examining medications with a healthcare provider. If one of the first things you're noticing is your kid's sleep is disrupted, what medications are they on? Could any of them be the culprit? Would removing one of them or replacing one of them severely change how your child is sleeping? Another, reinforcing all those good sleep habits. Establishing a regular sleep, and I'll even say nap schedule. Naps that are around 30 to 40 minutes, we used to call them power naps, they actually add to the time that people are actually getting sleep at night. They are positive if they're nice and scheduled. If you know, oh, well, my child's going to sleep between 2 and 2:40 every afternoon. And if that's set into their schedule, that's actually incredibly helpful. It can actually reduce some of the symptoms of poor sleep or not getting enough sleep. So I would say that's wonderful. What you're doing is you're helping to train the body to get into a particular rhythm. And once your body gets into a particular rhythm, it will keep that rhythm. And it will help to regulate all of your systems, your immune system, your digestive system, just every system that you need to be working together. Does your schedule that you've planned take into account competing demands? If you create a schedule that's not going to work in real world, then it's not going to work in the real world. And you might as well not have a schedule. No caffeine within a few hours of bed, dealing with or trying to deal with any worries before bedtime, whether that's talking them out or actually journaling. We found that journaling to be highly effective, someplace where kids or others can actually write down their concerns. and then engaging in relaxing activities shortly before bedtime. On the flip side, we understand that some of this engagement in enjoyable activities might include phones and TVs. And that's going to be a little bit counter to creating a great sleep environment. Because what you're going to want to do is start to not just slow down the child, but also slow down their brain. And so some things that tell your brain it's time to sleep is one thing being dark and it being quiet. And one of the biggest sources of light and noise is TVs and kids who sleep with TVs on. And so having to turn off TVs, sometimes having to go to this extreme level of removing TVs from the bedroom. I say if you live in an environment, I actually live in an environment where there's a lot of light all the time. I love that during the day, excuse me, but it's really horrible when I'm sleeping. Instead of I can get blackout curtains, which I haven't gotten. But you can also, let's say at Walmart or some other place, you can order wonderful sleep guards, or not sleep guards, but like kind of eye coverings, those coverings that people use when they travel, and put those on in order to make sure that it's actually getting dark enough for your brain to be reading, oh, it's dark, I'm supposed to be sleeping. If it's a very loud and noisy area, I strongly believe in earplugs as much as you can, because all of those noises are likely to say to your brain, you need to wake up, be aware, be alert, be ready to go. And that's going to harm sleep. Okay. Another big thing is cutting down on non-sleeping time in bed, but also cutting down on the amount of time that you're spending sleeping in other places. If your child gets used to falling asleep on the couch, they're going to need the couch to fall asleep. And they're never going to start associating their bed with their sleep unless they actually start going to bed in sleep. Starting to go to sleep in bed. That also means that the bed should not be a place where you're doing homework, where you're playing video games, where you're watching TV, because then all of those things are the things that you do. When I go to bed, I'm not about to go to sleep. I'm about to do all of my activities. And this can be particularly hard, particularly if you're living in a small environment, because oftentimes the bed is going to be taking up a lot of room. And so not using it for all of those things is going to become more difficult. And so being really strategic about that, or either somehow changing the way the bed is arranged when it's being used for something else versus when it's being used for sleep, something that can signal to your body that it's time for sleep. And that's going to be part of setting up that sleep routine, avoiding visible bedtime lights, avoiding lights even when you wake up in the middle of the night. And then as soon as you wake up, you want to expose your child and yourself to very bright light. Bright light says to your body, it's time to get up. It's horrible, but you need to flick those lights open or those lights on. They need to be as bright as possible. And you need to expose yourself to those lights for at least 20 to 30 minutes. And your body will eventually say, okay, I guess we can't give up. It's time to be awake. It's one of the most effective things. You just don't want to expose yourself to bright light when you're trying to fall asleep. And then what we've noticed is regular exercise helps people sleep really well. And last but not least, I always like to put out there, because sometimes you can feel like, oh, there's a lot of things that I need to do. Try to be realistic. There are going to be times when your sleep schedule or your child's sleep schedule gets disrupted. Something happens. You spend a week at the hospital. Your child has severe pain episodes. They are going through a particularly stressful time, and then their sleep is disrupted. Whatever is going on, there are going to be periods of time where sleep gets disrupted. The best thing, though, is how fast can you bounce back to a regular established routine? And if you already have a routine that's really clearly laid out, it's much easier to bounce back into it than if you never had one to begin with. And last but not least, if problems continue or if you suspect something that's more than what you can handle, that's when you need to start really bringing in licensed sleep medicine specialist or a behavioral sleep specialist to see if it's sleep disordered breathing, to see if it's periodic limb movement, to see if it's some extreme version of insomnia that's going to take another level of intervention. So let me go through what's going to happen, because that's what you can do on your own. Let's talk about what happens when you start partnering with healthcare professionals who are specialists in sleep. Here, let's start with sleep disordered breathing and periodic limb movement. Now, the only way to really diagnose this is going to be through an overnight sleep study. Common treatments I've mentioned before for kids, particularly, it's getting rid of those enlarged tonsils or adenoids right there. versus it for adults, it's going to be CPAP. It's going to be getting those machines that push that air into your throat to keep you breathing. Oh, and I also want to mention with periodic limb movement issues, what we're seeing there, though I haven't seen it as much in sickle cell disease, is they often associate that with a lower level of iron. So some treatments that have been used in other populations include iron supplements, dietary changes, and also certain particular medications to address those issues. Now, when we start moving into behavioral sleep problems like insomnia, there, if they suspect it might be sleep disordered breathing or they want to pull it apart, an overnight sleep study. But sometimes I will say overnight sleep studies might take a while to get scheduled. In the meantime, you can still look at these other things using sleep actigraphy if they're being used clinically in the sleep center you're working with, using sleep diaries, and using behavioral sleep questionnaires. If everything points to insomnia, I'd still get the overnight sleep study down the line, because remember, you can have insomnia and sleep disordered breathing, but there you're likely to kind of, if it's insomnia, go with another type of treatment. Now, many people think, oh, well, I'll just take some type of medication in order to address insomnia. In reality, cognitive behavioral therapy for insomnia has been found to be as effective or more effective than most insomnia-based medications, partially because of what we believe to be the nature of behavioral sleep issues. So I'm going to dig into this a little bit, and particularly what I think might be going on for individuals with sickle cell disease. Now, we have what we call the 4-factor model of insomnia. This 4-factor model includes what we call predisposing symptoms. So things that might predispose you to have sleep problems. So for our kids, it's sickle cell disease. Just having sickle cell disease puts you at risk. And it might also be developmental stage. Adolescents tend to have more sleep problems than younger children. And so what's going to happen is you're going along fine, you do not have insomnia. That's going to be a little red bar on the bottom. And then you have a triggering event or triggering factors. And so that might be extreme pain that appears in the night that disrupts your sleep. That might be a long-term hospitalization. That might be bladder-related issues. I have a number of kids who report that they're waking up multiple times a night to go to the bathroom. That might also be medication effects or some other factor that we haven't quite identified. So what that's going to do, just like if I was to go on an overnight trip someplace else or be in another time zone, it disrupts your normal sleep pattern. And it starts kind of leaping you over into the place where you're having problems going to sleep, staying asleep, and all of those pieces. But what happens over time as you keep waking up in the middle of the night, or you keep staying awake longer than you need to, is there's going to be these perpetrating factors that start creeping in. Well, what am I doing when I stay up longer? Well, maybe I'm reading a book. Well, maybe I'm playing on my phone. Well, maybe I'm watching TV that comes on in the middle of the night. Maybe I'm playing video games. Maybe there's other things that are, as we say, perpetrating or enforcing or helping this behavior keep on. So even when the triggers are gone, no pain, no hospitalization, I don't have to get up really to go to the bathroom anymore, these other behaviors and these other factors are helping to keep me awake. And then what's going to happen is once you get used to staying awake, once you get used to having this bad sleep pattern, it just continues on. It just becomes a habit. It's a habit that's hard to break on your own. So what CBTI, or cognitive behavioral therapy for insomnia, actually does, it attacks what we call these perpetrating symptoms or these perpetrating factors. It attacks those as a way of removing some of the things that are enforcing keeping you up in the night. So if we know that part of what's keeping you up in the night is that when you get up at 2 a.m. in the morning, you tend to go and read a book or you watch this particular show, guess what? You don't get to do those things anymore. We want to remove everything that's enforcing this. Some of the things that might be enforcing this might also be some of your thoughts around sleep. Well, I'm just a bad sleeper. This is just the way it is, that are keeping you going. We want to address those as well. And what we found is when we address all the behavioral and cognitive issues that keep the bad sleep going, all of a sudden people are able to get to a place where their sleep becomes easier and then easier and then easier. That conditioned response goes away and they're able to go back to normal, good, healthy sleep. So some components of this that people use are everything from what we call cognitive restructuring. That's going to be changing the way you think about your sleep problems, that this is something that you can actually change and modify, which sometimes tends to be one of the biggest barriers we deal with, to using sleep restriction. This is where we actually say, well, you're only getting 4 hours of sleep every night, but you're taking 8 hours to get those 4 hours of sleep. So we're actually going to keep you up long enough so that you're only allowed to have 4 hours of sleep. We're going to force your body to get all 4 hours of sleep back to back to back. And then, because that's really not enough sleep, we're going to slowly start branching you out until you're sleeping 5 continuous hours of sleep, 6, 7, until you get to just the right amount of sleep for yourself. We're going to control all the things that are trying to get in the way of you getting good sleep. We're going to address any sleep hygiene issues that you have. And we're also, because sometimes what's keeping you awake is just being so tense, and you're used to being tense and alert and awake in the middle of the night, is we're also going to likely take you through some type of relaxation training to help you to unclench all those muscles and get that good sleep. So that's what you should expect if you're thinking about like CBTI. And what we know for kids, because there haven't really been CBTI studies or cognitive behavioral therapy studies for kids with sickle cell disease, but there have with general child populations. We've seen really promising results for addressing sleep problems. But what's really been nice is when you look into sleep studies that have particularly targeted kids with physical conditions and those who experience pain. And for a nice, there was a nice study of 21 adults with migraines, and they actually found that CBTI reduced the number of migraine days and actually reduced the amount of pain-related activity limitations. Overall, we've noticed that it seems to be effective in the populations that we're looking at, and we're seeing overall improved quality of life. So we're really hopeful. I think at the individual level, clinically, we've seen that CBTI works. I wish I could highlight the study that says that it works beautifully in the majority of kids with sickle cell disease. We're just based upon my clinical experience. Okay, so last but not least, I wanted to address fatigue, because truthfully, we're still getting our heads around fatigue. We didn't realize how much of an issue it is. One recommendation that's coming out in relation to fatigue is, for one thing, there's a number of very promising medications that are coming onto the market that are focusing on fatigue, particularly in adults with sickle cell disease. And I'd love to see those really make their way into addressing fatigue issues with kids. One other thing, however, that's been used in other populations is having individuals work with occupational therapists. And part of it is about helping people to actually work with the amount of energy that they have. So they're using things of what they call activity pacing. So pacing your activities so that you're able to do the things that you want to do, but maybe you're pacing them in a way where you're giving yourself enough rest time in between. We talk about energy conservation and rest activity balances. And we found this to be very effective in other populations that face fatigue in relation to improving quality of life for both kids and their families. I just think all of this really needs to be research for kids with sickle cell disease, and we need to have a better sense of it. But I think there's a lot coming down the pipeline, so I can still be very encouraged. Okay, so that kind of takes me at the end of this presentation, or at least this overall overview. And so what she's come out with is high amount of sleep problems, including fatigue, huge impact. But I think that there's a lot of different ways that we can really both assess or kind of get a sense of what might be out there for individual kids and adults. And there's a lot of promising or in-use treatments that just need to be applied to sickle cell disease more frequently and more consistently. Overnight sleep studies to make sure that we're getting at sleep disordered breathing. There have been wonderful studies in sickle cell that have actually found that individuals on CPAP, where we're addressing their sleep apnea symptoms, tend to have reduced pain and reduced other kind of indicators of disease severity. And I think I'm really looking for the next wave where we can say the same thing about CBTI and issues to address fatigue. And so that's going to kind of finish me out in relation to things that I wanted to cover. And this is where I just want to thank everyone for their time. I know it's a Saturday afternoon. It's around 3 something where I'm at. I don't have a clue what time it is there. But hopefully we can kind of start into answering any questions or starting a good discussion.
Wonderful. So we do have some questions that we're going to address.
Do you want me to stop sharing my screen? Would that be helpful or?
Sure, thank you.
Mm-hmm.
And so you can put them in the Q&A as well as the chat, and I will get to them. So the first question from Lisa Rose is, have they looked for correlation between periods of cyclical patterns of low hemoglobin and fatigue?
I think that is an excellent question, because what we have noticed anecdotally is people who are on chronic blood transfusion tend to report less fatigue. What we are having problems with, because this is actually something I was hoping to be able to research, is we do not have the technology to measure hemoglobin on a daily basis that I think it needs to be measured on in order to actually see how it relates to fatigue. So I can look at, through daily diaries and other technology, I can take a look at everything from stress to mood to all those pieces, but hemoglobin levels, it's really hard to assess until we kind of cross that barrier. It's hard, we haven't been able to perfectly correlate it. What we have noticed, and these are based on one-time measures of hemoglobin, is the relationship between hemoglobin levels and fatigue is not consistent. Some studies have found it to be related and other studies have not. And we can't figure out the systematic differences between those that are making them different. Like there doesn't seem to be any rhyme or reason. And I think it all has to do with when we're measuring hemoglobin and when we're measuring fatigue. I think if we were doing it on a daily basis, I could answer you. Because we're doing these one shots, it's really, we don't have the science to say it definitely yet. And we don't have the longitudinal studies either to say it yet, which I think is particularly important.
She also asked, how would we go about presenting this to pediatricians or hematologists?
Well, when it comes to, and so by this, do you mean like sleep problems or the possibility of sleep problems, or I'm assuming that's what you mean?
Well, she asked the first question about the correlation. And then I think in general, just how would you go about presenting, quote, sleep problems that you may have noticed as a parent
Yeah.
to the pediatrician?
Mm-hmm. And I think we're trying to, like on the side, like I've done presentations for other healthcare providers and trying to encourage them to ask the questions. But if they're not asking the questions, you need to provide the information anyway. If you already, or if your child is already using technology to track their sleep, I would bring in that information for them to see. So if they can see the sleep is disrupted. I would, worst case scenario, just tell them, my kid is snoring. I have a concern about sleep disordered breathing. I think that my kid needs a referral for sleep disordered breathing or for sleep apnea just to check, because I know this is a symptom. That would be one piece. The other is that my kid is not sleeping very well at all. And it's, I think it's impacting them academically. I think it's impacting them in risk and their fatigue. What can you help me with? Is there a way, if you can't help me, can you find someone who can help me, a behavioral sleep medicine person? I think that we have to be real. I mean, I love a system where it was all nicely built in, and I'm trying to push for that. But until that happens, it's once again, unfortunately, the families, you guys have got to be the advocates in the room. And so you have to show up with like, this is what I got. And even if it's just something like the bears, which you can print out your say and say, these were all the places I said yes to. So these are all the issues. And I know this is related to possibly sleep disordered breathing, and it's common in kids with sickle cell. I need a referral. And I also know with certain health, depending upon your health insurance, because I've dealt with different people in different states with different types of health insurance. Sometimes you don't need the referral. Sometimes you can actually make the appointment on your own and make your own referral. And then other times you need your healthcare provider to actually say, okay, let me set you up for that referral. And more than likely in that referral, they'll send you either to pulmonology or they'll send you to neurology. Those are the two big areas that address sleep issues. Or they'll sometimes just send you to a freestanding sleep center in order to get evaluated and have that information sent back to them. So I'd say really whatever you have, present it to them, tell them what your concerns are, and don't let them dismiss it. Keep coming back with the same concern. They're going to figure out, oh, this is the one who has sleep problems until sleep problems are addressed.
Okay.
That would be one thing that I would work on. Oh, and if you are seeking CBTI, I mean, truthfully, there's a number of board certified sleep behavioral specialists. So they're not MDs, they're actually psychologists and others that have been certified by, I think, the American Sleep Medicine Association as behavioral sleep specialists. And I believe you can, there's an association of behavioral sleep medicine that they might have actually an active list of people who are certified. Where then the same way that you might not need a referral to see a psychologist, you can also possibly make an appointment with somebody who practices CBTI to help your child or you address insomnia symptoms.
And that would be, again, cognitive behavioral therapy for insomnia.
Mhm.
Uh, so Dr. Hager says that they often use Oxbryta to see if fatigue improves.
Oxbryta?
Oxbryta is one of the 4 FDA-approved modifying therapies for sickle cell disease. So there's
Okay.
hydroxyurea, there's Indari,
L-glutamine, I
Oxbryta,
know.
Oxbryta, and Adecvio.
Okay, so that must be, I always try to keep up with, but I think the two that I often see the most are hydroxyurea and L-glutamine.
Right. So these
Um,
two, Oxbryta and Adecvio, came out in November 2019.
okay, it's amazing. I have not read as much on them at all.
Mhm.
I've read entire articles when L-glutamine came out. So I must do some more research on those. I have not heard much about that particular medication
Okay.
as being FDA approved because I usually try to keep a listing somewhere.
Right.
So I would have to do my research on that one. I don't know if you found any type of impact on fatigue. I knew that there was a number of clinical trials with a number of different, I've talked to a few different companies. I'm horrible at remembering drug names. I will tell you that right now. Particularly given all the different clinical trials that are starting to focus on fatigue in sickle cell disease, they're starting to use it as a major clinical endpoint.
Yes.
So I'd be interested to kind of read more and also see more if that's having an impact. Because I hadn't heard about anything, I haven't seen anything published in the literature that's had an impact on fatigue. Have they mentioned, or they, I forget, you said Dr. Hager, have they
Mhm.
found any type of impact?
So I'm going to, Dr. Hager, I'm going to unmute you. There you go.
Am I on video too, or just mute?
Uh,
Unmuted.
you're unmuted and we can see your
Logo?
uh-huh.
Oh, okay, well, hang on. Let's see here.
Okay.
I'm trying my best here.
It's okay.
Oh, I'll just talk. I was trying to, I didn't want to hide. But yeah, one thing we know about Bacillus or Oxbryta is that it raises hemoglobin, and some people up to like 3 grams. And we've often been concerned that so many of the important side effects of having sickle cell, such as fatigue, which is long recognized and understudied, it's just anemia. That we've
Yes.
when patients have a low hemoglobin and are tired, we just put them on Oxbryta. And this has been anecdotal. I know the company is looking into this too, but it's probably about a little over half the patients report more energy as their hemoglobin comes up, which would make physiologic sense. But we need obviously larger studies to see exactly what's going on. So interesting question, and thank you for your talk, is how this might affect sleep. Because I was wondering if the hemoglobin was higher, would they be able to sleep better too?
And there, I don't think that we found anemia to be related, or at least we're still using those one-time measurements though. I so look forward. I've talked to actually people in engineering saying, is there a way that we can be measuring daily hemoglobin levels? Because I think that would change our ability to really disentangle this relationship between hemoglobin levels and sleep. I don't believe that I've seen like a strong connection, and I've seen such mixed findings with anemia and fatigue, but I think I've seen the same impact that you've seen in relation to people who are on chronic blood transfusion, is that a number of them respond and report much less fatigue. So I think that anemia is playing into it strongly. But I think some early research that we started to do also started to say over and above at least our one-time hemoglobin levels, insomnia also is playing into it as well. And so, and I suspect there's also a cognitive piece because we've got a number of kids who, have the silent infarcts. And if you know that, sleep is very much regulated by the brain. So anytime that brain has been damaged, there's a likelihood of there being some type of disruption in relation to sleep. And so I feel like there's so many different pieces to disentangle with this. But I do think that, the chronic blood transfusion, it sounds like there's a medication that you guys have been trying. If you do have some good anecdotal information, you want to gather some information and publish, that would at least start to kind of move us down some directions in relation to some medications we can take a look at. Because I think that at one time I knew some people who were trying to look at some of the cancer drugs that were being addressed I think somebody had mentioned one of them, but then it was counterindicated for sickle cell disease. And I said, oh, no, let's not. And so I think trying to think about stuff that already is working within sickle cell disease, so we know it's relatively safe, is going to be very important.
Thank you. Another question says, not sure if anyone addressed using supplements like melatonin or whether or not it is beneficial to help with sleeping.
Okay, melatonin is very interesting because melatonin is both something that naturally kind of occurs in the body, but it's also something that's being used. And unfortunately, it's not very regulated in relation to its use. I have run across patients who are on melatonin who have reported anecdotally how it's been helpful for certain insomnia type symptoms. However, there has been no clinical trials. We don't have a good sense of exactly how many patients with sickle cell disease are using melatonin and what are some possible side effects, like how it might be interacting with other aspects of sickle cell disease. So right now I can't, hugely recommend it, particularly because I think it's a part of this very unregulated system. I wish that there was some really good, at least initial information, but all we have is anecdotal information. And I do know that it's being pushed as part of kind of safe, organic sleep aids generally out there. And so right now I haven't seen any negative effects of melatonin, but another big piece about melatonin is it's all about timing. Your body is naturally producing levels of melatonin, sometimes triggered by light. So we're in the sleep field, sometimes we're saying, you might not need as much melatonin if you're timing your exposure to light correctly, which is going to then start to increase and decrease your levels of melatonin appropriately. So the whole making sure you're not exposed to light closer to bedtime, actually reducing your exposure to light, and then actually introducing yourself to light almost as soon as you wake up for at least 30 minutes. An interesting intervention that's now being used with cancer patients and a few other sleep insomnia related patients is bright light therapy. And people are starting to look at how different levels of melatonin and other sleep neurotransmitters are actually changing in relation to response to light. And I think it's shown to have less side effects. So I would that's why I think I more encourage kind of the light exposure piece more than I encourage the melatonin piece. So it could be safe, it could not be safe. I can't say anything definitive, and I wish I could say something definitive.
Thank you. Lisa Rose says, so I wonder if an increase in I'm assuming the retic count, would also play a part in fatigue as the body is reviving up and using more energy to get caught up.
Mm-hmm. And so I believe what you're kind of getting at is that energy balance piece that we kind of see in relation to rest versus activity levels during the day. I haven't seen retic count to be kind of related in, or even I'm not even sure studied in relation to fatigue in sickle cell disease, separately from hemoglobin. So it would be hard for me to say. I do know that, and maybe I'm starting to relate this to a qualitative study that I read recently related to fatigue. It was adolescents in Ghana, and they were talking about how they handle their fatigue. And it was very much kind of I rest in order to kind of boost my energy like a car, and then I utilize it effectively, and then it runs down again. And so it's kind of that same kind of up and down pattern. And that your comment kind of reminded me of that in relation to kind of, we're proposing the same biological thing, whether it's with anemia or whether it's related to retic count. But until we can really continuously measure those things on a daily basis, I think we're going to have a problem making those connections. And I think that's where our methodology and our science have not caught up with what's going on physically for patients with sickle cell. I can measure that if I was working with patients with diabetes. I can watch their A1C levels on a moment by moment basis. I can't look at hemoglobin levels on a moment by moment basis or retic count. And I think that's problematic for us. And until we can get over that barrier, I can't say definitively. I wish I could say more. I feel like there's so many holes in the literature that I wish I could fill. And I don't want to speculate because I don't want to, we're very good at targeting the wrong thing and wasting a lot of people's time. And I don't believe in that.
So let me just take a pause and say that again, this and all of our presentations are being recorded, and this will be posted on our website in about a week. I am looking now at the Q&A, and so it looks like we've asked those questions, but Mrs. Thomas says the questions are not posted in the chat. So if you're posting questions in the Q&A, they will not be in the chat, but we are looking at the Q&A. So feel free um, to post your questions in the Q&A, as well as in the chat, and/or you can raise your hand and I'll acknowledge you. The next question is, well, one suggestion is more daytime sleep studies in sickle cell patients. And then Miss Elaine Marie says, can we address daytime sleep studies for sickle cell patients of all ages? Undiagnosed narcolepsy can show symptoms such as fatigue and migraines.
That is a great point. That is a great point. It's very interesting because when you say daytime sleep studies, the first thing I think about is really getting at how people, we call it, instead of just thinking about sleep, it's sleep-wake patterns that we're getting at. And in a lot of ways, we're starting to have the data to be able to do, I think, exactly what you're talking about doing. Because generally for the sleep watches, for sleep actigraphy, which I know when I have sleep studies, I just finished up a big study of about 123 kids with sickle cell disease, 8 to 17. We put sleep watches on them. They didn't just wear them at night, they wore them during the day as well. Where we're starting to go, I think, overall within pediatric research is trying to take that daytime activity patterns and create the same type of sleep algorithms that we've created for the nighttime and translate them into the day. So we can talk about how many times people are napping, patterns of napping and waking throughout the day. I think we're starting to finally start to look at that data, but we haven't done it as periodically as we need to for individuals with sickle cell disease. I've started, I think there was a recent study that started to try to turn that around and talk about levels of physical activity among kids with sickle cell disease, but not as much like how often they're napping, not as much how much time that they're spending in prone positions. That's also kind of hard because kids spend a lot of time in school. And I know right now a lot of people are doing virtual school. My nephew is full out in virtual school. So he's spending a lot of time sitting, even if he's not sleeping, I hope. And so I think we're trying to also get a better sense of how we can get at those daytime behaviors that I think are what we're now calling the daytime sleep studies that you're trying to get at. And yeah, I would like to say that we have not looked at narcolepsy or possible narcolepsy within the population. I think I was really surprised a number of years ago that we are not taking a better look at periodic limb movement sleep. It feels like we've almost exclusively focused on sleep apnea in kids with sickle cell disease. Almost every other study, I've added in some behavioral studies and more people have added there, but we haven't looked at a lot of the other sleep disorders. I mean, I think I detailed 3 studies on periodic limb movement. And I updated this talk recently and I was like, there's still nothing there. There's still nothing, despite the fact that I know it's been related to poor outcomes in kids and adults. So I definitely think that's another area for us to get a better sense of like if there's some other daytime sleep disorders going on. So thanks for pointing that out. And I've actually put a little note to myself to see if we might have some data that can start to address like issues with narcolepsy. I'm also looking at the chat too. And so
what I'm going to do now is just ask, at this time, we always have people who can relate. And so I want to open that up. If you can raise your hand, if you're you or your child going through something that you want to be able to ask something specifically, please feel free to raise your hand and or again to raise that question. So while we're waiting, one of the things, so here's my hypothesis that I look at in terms of sleep and how it actually all starts and how that continues into adulthood. And I would like for you to share with me your thoughts. So, and I believe that there's some validity. So part of it is, again, that our sleep is off because of our circadian rhythm, because of being interrupted by pain. So when we're not sleeping and we have pain, that tends to wake us up, say, 1 or 2 o'clock in the morning, and parents can relate. Why does my child have pain at 2 o'clock in the morning versus 2 p.m.? And so I believe that that actually starts the wheel going, and it continues even through adolescent and adult in terms of having your circadian rhythm off, because the pain tends to occur at different times.
Mhm.
Um,
And that's part of my hypothesis, except
mhm.
part of it is also that there's ways to reset the circadian rhythm. That's the beauty of the circadian rhythm. It's the, you know, the circadian rhythm is a 24-hour, actually 25-hour body clock that we're all dealing with. It functions in relation to like raising and lowering levels of everything from melatonin to like the amount of heat that your body is generating and cold within it. Is that what we found is things like CBTI, so cognitive behavioral therapy for insomnia, actually resets your circadian rhythm. And that all these different events actually reset your circadian rhythm. Circadian rhythm is one of those things that at least we have found to be very modifiable by behavioral or environmental cues, whether it's light exposure or whether it's, kind of reducing distractions so that you can actually consolidate your sleep. So I think what you're saying, because that's exactly kind of my hypothesis too, that I was putting out there, is that we do have these events, these triggering events, which is very consistent with the idea of that four model that I showed you guys, that disrupt our overall sleep pattern. And once it becomes disrupted, we keep it. Like there's something that we talk about in pain literature called pain anxiety. You start anticipating the pain because you've had it. You just had a traumatic event that happened at 2 o'clock. It could be pain. It could be something else. It could be, I don't want to use, well, I guess this example works. I used to know this house in my neighborhood that's right on a corner that somehow it was so close to the corner that cars periodically drove through it. So this house has been destroyed probably 2 or 3 times now, because of people taking very sharp turns and going directly through the house. I don't know why they keep rebuilding it, but I think what has happened is like we are the house on the corner, and every once in a while something bad happens, and that might be a severe pain episode or a hospitalization. Maybe you're being hospitalized for something that's not a pain episode. Maybe it's acute chest. Maybe it's something else. People do not sleep well in the hospital. The hospital is a horrible place to get sleep. But as part of being in the hospital, people come into your room 2 or 3 times a night and turn the light instantly on. Bright light flashes, you're awake, everybody's awake. This happens over the course of a few days, and then they send you home. Your sleep and circadian rhythm is now used to getting up 3 to 4 times per night. It's going to take you a while to shift back to getting a full night of sleep. You've got to retrain your circadian rhythm because you're anticipating the light coming on, just like you're anticipating the pain, and or you're anticipating the bad news, or what you're anticipating the car coming through the house. So we've got to reduce that anticipation, which is sometimes retraining your brain not to expect it, and that'll help to reset that rhythm. So I think yeah, you can get caught into like rhythms, but there are ways to change it. And I think that's where we get caught, is we assume that there's no way that we can ever change this rhythm because we've
Yeah,
had it for so
but
long.
but I also believe that if we can um, really put this out there in our community, then we also need to provide what people can do to be able to reset. Because there are many, many people who just live with the fact that this is just what it is.
Mhm.
Many adults just say, I just stay up all night and I don't go to sleep until 4 or 5, and that's when they finally fall asleep. So I believe that, which is why we're having this mini seminar, is
Yeah.
because I think that we need to raise this issue. And but I also believe in giving people viable solutions.
Mhm.
So we also need to be able to share, like you just said, we can. So I think perhaps for the next one that we do, that we need to also talk about what we can actually do, because people are not in the habit of, quote, resetting their circadian rhythm.
Mhm.
Um, they're not even sure that, what's going on, but we need to, in addition to CBTI, we also need to see things that we can actually do to share with folks what they can do.
Mhm. And actually, even my focus a little bit on the sleep hygiene stuff are all the activities that we can do.
Okay,
The light exposure, the taking the TV out of the room, those are all parts of resetting your circadian rhythm or
great.
training your circadian rhythm to be. I think I didn't put them in that, I didn't state them in that same way, but they're all things that you can kind of do for yourself before you pull in a professional to help you like regulate it out, that people do all the time to themselves. And sometimes we notice that we're doing and sometimes we don't. I've noticed some people who start to wind down. They have a routine where the TV goes off. They're sitting in a small place in their couch with like just very little light, and they're winding their way down until they slip into bed. Other things that you are doing is you're not just training your circadian rhythm. You're also you're kind of training your environment where you sleep, and that's your bed. If everything is happening on the bed, then no sleep is happening on the bed. And that's one of those contributing factors that's keeping you up. If your bed is the place where you come and play video games, when you get up and try to go to bed, the first thing you're going to do is lay down, and then you're going to reach for your phone or your iPad or whatever other device, and you will be playing away. And then 5 hours later, you'll realize I've had no sleep whatsoever. And it's because you might as well be sitting at a desk playing away, because you've taught yourself, this is where I play, not this is where I sleep. And so part of that is also when all of those little recommendations that I had during the talk are all pieces that we use to reset the clock, or at least to remove barriers to resetting the clock, because there's so many barriers that we create and that we have that enforce us staying up until 3, 4, or reinforce us getting up at 2 or 3. And I've run across many parents who'll be like, I thought my kid was sleeping well, and then I popped awake at 2 o'clock one night, and I noticed this noise coming from his room, and I popped in, and there he is, just like suited up, playing his video game. He's looking at me wide awake, and I'm like, what are you doing up? I had no idea he was up in the middle of the night. And I hear this story over and over again too. So that's where I also think it's good to have those conversations with your children, because they might not be telling you they're getting up multiple times a night, and you would have no idea. The younger ones, they will tell you. They will come, they will crawl into your bed, they will bother you. The adolescents, they'll just be up. You'll think they slept all night long, and they have been up for like 4 out of the 8 hours, talking and doing stuff. And then they'll be like, I'm so tired. And you're like, you were asleep 5 seconds ago. Why are you so tired? Why can't I get you up in the morning? They are not sleeping.
Well, let's see if there's any other questions. So if you have any questions and you're on the Zoom with us, please feel free to raise your hand and we can actually unmute you, or put your questions in the chat, or you can also place your questions in the question and answer box, and we will actually uh, ask those questions. Okay. Golda, did you have any final remarks as well? Did you have any questions?
This was just absolutely excellent. It was so
Yeah.
informative. I feel like I learned so much. I certainly am having a similar situation with my younger brother. So appreciative for this insight.
Good.
Thank you. Wow, Dr. Valerie, this is great. This is part 1 of 3.
Mhm.
We're so honored that you joined us. This is excellent. Our goal literally is not just to educate, but we really want people to take whatever steps that they can do to improve their quality of life, which actually means improving their sleep.
Yes,
And
you get good sleep, it changes your life. I really
it
do believe
changes your life.
that.
Yeah, it does. It really does. So I want to be able, but I want to make sure that we have the space for any questions. We're not rushing anyone, and/or if you want to be able to share your story. If you have any questions, please raise your hand or type it in the chat. And we'll give it a few more seconds. Okay. Well, this has been excellent. We do have a question. Thank you. So we're gonna R. Bean, you are allowed to ask your question.
Hello, can you hear me?
Yes, we can.
Yeah, just in regards to, thank you all for hosting this first and foremost. I've had personally some experiences just with like priapism, and then that, once that occurs, then it's difficult to kind of fall back to sleep. And, so do you have any like suggestions as far as dealing with that?
Thank you for that question.
Yeah, and I think because I focused a little bit more on, well, actually, no, priapism is still common among boys with sickle cell disease. But interestingly enough, it's not been cited as one of those things that has been disrupting sleep. But I'm wondering if it's because I've been looking at bedwetting, I've been looking at pain, but I don't always think that people are reporting their pain as priapism. And so I don't think that we've made that connection yet. Versus I actually knew someone who researched a lot in relation to priapism, who was a pediatric physician at UNC. And so I wish I had more information related to that, because I'm not even sure of like the standard treatments for priapism as much. And I don't know, Dr. Rowley, if you know some of those,
Well, it
and
makes
how that
sense
might play into
because,
it.
well, it makes sense because it's extremely painful.
Extremely.
So it needs to be dealt with within the first couple of hours. And so that means that the young man is they're awake, having to deal with it. And if it's over a couple of hours, now have to go to the emergency room and deal with all of that. So to me, when we talk about pain, priapism, I think, is part of that pain syndrome that perhaps that I'm saying but perhaps should be looked at as well. It just seems that it hasn't been teased out, but I think it is part of the pain syndrome. Dr. Hager?
Sorry, you caught me multitasking. Could you repeat the question?
So the question is that about priapism, and the young man was just asking Dr. Valerie for any assistance because he experiences priapism, and I was just saying that is painful. So it should be part of the pain syndrome when looking at that actually interrupts sleep.
I think for him specifically, it has disrupted his sleep and then led to problems falling back asleep after the experience. And I am not as familiar in relation to particular treatments related to priapism. I did know that you need to kind of seek professional help, especially if it lasted after a certain number of, I don't know if I would even say hours.
Yeah, priapism is an interesting symptom that, just like fatigue, unless you ask about it, you won't hear about it.
Mm-hmm.
And it affects around 3 to 7% of our young men. And it does disrupt sleep quite a bit. We have patients that get it almost like a couple times a week. And even when they get it and they wake up, and it's hard to get back to sleep, and it can be, obviously, as the gentleman was saying, quite disruptive. There are some basic treatments. Believe it or not, taking Sudafed helps some people for that, but then it wakes them up too, so that's hard to go. Our most successful treatment we found is a modification of what they used to do at Dallas Children's for priapism, where they used to give 10 milligrams of leuprolide IM once a month, which is a anti-testosterone medication, basically. But you can imagine that dose, kind of everything went away. We've actually dropped the dose down to just 1 milligram once a month, and it's been extremely successful in reducing, actually eliminating most priapism without affecting any other functioning. And we've been watching the bone density very carefully, and we really haven't seen any significant bone loss. So if it's something that is constantly interrupting someone's quality of life, then our go-to medication is 1 milligram of leuprolide once a month, IM. And that's been extremely helpful for almost everyone we've given it to. The one thing you have to be aware of is that since it is a partial agonist-antagonist, after the first dose, sometimes things get worse before they get better. And so a lot of us will put people on something like ketoconazole or Casodex the few days before that, just to keep that flare from happening. But yeah, if it isn't impacting quality of life, you just can't get back to sleep after you've been through that. And even our young men that can handle it at home, they get up, they take a shower, they do different things. Then they've been up, an hour or two in the middle of the night, and they just can't get back to sleep with any quality time.
Mhm. Thank you. And I do know that that's one of the reasons for recommending hydroxyurea as well, that reportedly it can have an effect, but I'm not sure if that's what you found, that if they're on hydroxyurea, that it can lower the um, having priapism.
For some people, it can. And the other interesting study called by Novartis the Spartan studies, it seems that crizolizumab seems to have a pretty potent effect on reducing priapism. So hopefully we'll have that data in about a year. But we always, if someone's SS hemoglobin, we always try to maximize the hydroxyurea. Even with all the new drugs, it works the best. It's got the best track record for organ protection. As most people on this call know, if you're born now with sickle cell, they start giving it to you at 9 months of age, planning to keep you on it for life, because it does have so much organ protection. But even in those patients that's not helping, or those who can't take hydroxyurea, then the next go-to medication is usually like leuprolide injections.
Thank you. Anyone else? Thank you, Mr. Bing, for that. Anyone else have a question? Well, wonderful. Dr. Valerie, this was great. We look forward to parts 2 and 3 on sleep.
And
But
I think for part 2, we're going to be hearing from at least one of the researchers right now, who I think is also a clinician, who is assisting with one of the large scale adult sleep studies, sleep intervention studies that is going on right now. So I'm really interested to hear kind of the latest off the presses information coming from that might also be addressing some of these issues. But I did want to thank everyone for coming, but also thank you for giving me kind of working in the area of sleep and sickle cell disease. I think you've all given me some ideas about areas that I need to spend a little bit more time on, particularly making sure that people have a better sense of circadian rhythm and how easy it is to disrupt that. Because I think even the conversation we were having about priapism, in my mind, part of it is also it's functioning the same way that some of these other like house, truck through the house mentality things are, is that once your sleep is disrupted, then you're having that anticipation of it recurring again. And that's part of what's kind of supporting keeping you up. And so it's not just going to be unfortunately disrupted that one night, but like future nights, the same way that any other pain experience, except that's such an extreme pain experience, is likely to have. And I definitely want to take a good look at narcolepsy, and I feel like eventually we're going to have to address the issue of melatonin in the field, and particularly how people are already using it and what that might mean for sickle cell, because I want to make sure that people who are using it are not having bad effects.
definitely. Well, again, everyone, we are thankful that you joined us here at Kyan Wellness Center in our part 1 of sleep and sickle cell disease, presented by Dr. Valerie. So thank you again for your time. And as always, we always have our linger longer. So we're going to stay on for a little bit, but we are officially adjourned. And but we're going to stay on longer just in case people have some additional questions or they want to ask Dr. Valerie anything. So thank you all. Have a great afternoon. And we're going to be here just a little bit longer though. So thank you. And where are you? Tell me what city and state you're in, Dr. Valerie, again. I know you're East Coast.
Oh yes, I'm in Richmond, Virginia. So I'm at
Oh,
I'm at Virginia Commonwealth University in Richmond, and so I've been here for about 4 years. Before that, I was in North Carolina at East Carolina University, and then for a number of years at UNC Chapel Hill. So
okay, and we're allowing everyone. We're taking off the mute and allowing anyone to, if they would like to ask a question. But we always have our linger longer. We find that people like that aspect. we are officially adjourned. So feel free to ask questions if you like, or comment. All right. All right.
I thought it was very informative. Thank you so much. Even though I'm an adult, I definitely look forward to your adult chat. I definitely took a lot of notes that I will be sharing with my husband and son tonight because I've been wondering about some of the things you addressed today. So it's very timely. Thank you.
I'm happy it could be helpful.
So Elaine Marie says Dr. Arthur Lewis Burnett at Johns Hopkins Urology is a fabulous resource as he specializes in sickle cell urology issues. So I will take note of that as well. Have you heard of him, Dr. Valerie?
No, and I know a few individuals at Hopkins, but I don't think I've heard of him specifically. I know a lot more of the people who are addressing pain-related issues, like Dr. Jennifer Hawthorne-Waite, and others who just specialize overall in sickle cell, like Dr. Pat Carroll. And so, but I don't know.
It's okay. Now we have a new name.
We have a new name. Like, they've got a very strong group at Hopkins. And that'll actually be where our speaker for the adult series or for the adult seminar is coming from that Hopkins group. So she's going to be representing and bringing in some of their more recent information. So
Okay. Wonderful. Excellent. Well, again, everyone, thank you for joining. And so at this time, what we're going to do is we're going to stop the recording and stop the live on Facebook. There we go. And wish you all a great afternoon